You good? Yeah. Yeah, they're going to go first. Thank you, Hansard. We are recommencing from the dinner break, continuation in outcome 1, which is still health policy, access and support, and closing the gap outcomes. I'm going to hand the call to Senator Shoebridge.
Thanks very much, Chair. I had some questions, I think, to the TGA. They're around the issue of medicinal cannabis and some of the difficulties that have come to our office about multiple compliance with different states, so different state regimes. Nice to see you. Thank you for being here this evening.
A pleasure.
Nowhere else to be.
Yep. On a Wednesday night in Canberra.
Yeah, Wednesday night in Canberra. Well, I've heard, and I'm sure you've heard as well, from clinicians who are so frustrated about the expectation that they'll be able to remain compliant with state-based real-time prescription monitoring programs. And there's a bunch of them, as you know, things like SafeScript, ScriptCheck WA, QScript, SafeScript New South Wales. When those systems don't recognise medicinal cannabis products due to non-standardised naming conventions, custom-loaded medications, inconsistent back-end mapping between the prescribing software and then the real-time monitoring programs. What they're asking for is some steps to have a mandated uniform national system. I don't know if you're hearing these calls and these frustrations, but we're hearing them. Are you aware of the problem, first of all?
So thank you, Senator. Professor Anthony Law, the Deputy Secretary, Health Products Regulation Group. I think it's safe to say we're aware of a number of problems with medicinal cannabis regulation and access, and we're obviously very active in the space of understanding the broad scope of those challenges, but also reform. Yeah. We've undertaken consultation. Certainly, one of the things we've heard is around the consistency of labelling, dosage forms, and the like. There is a challenge across medicines regulation broadly, which is that while, as the therapeutic goods regulator, we are responsible for certain controls around advertising, manufacture, import, export and supply, the states and territories under their own poisons legislation predominantly regulate how and in what way those medicines are prescribed and accessed.
Yeah, so and so I understand that there's a limit to which you have express, constitutional statutory control. But the end result is this melange, this total mess, where particularly if you're operating across jurisdictions, but even if you're not, you're trying to come to terms with all these inconsistencies. What the call we've heard is working towards a national standardisation of at least medicinal cannabis medication naming. Like even if we started there, that would improve accuracy, that would provide some protection as well for prescribers and pharmacists and patients, like the national standardisation of naming conventions.
Yeah, and certainly appreciate that, Senator, and obviously as the custodians of the poison standard, we're very, very keen on a standardised approach. We work very closely with our state and territory colleagues, including through the National Medicines and Poisons Advisory Group, which is in part designed to work towards consistent processes of pharmacy regulation and also pharmacy and prescribing. We have a couple of actions that we feel are likely to arise from our consultation, and part of that will be around how we administer access to medicinal cannabis. One of the challenges that we have currently is that under the regulatory framework, medicinal cannabis is accessed as an unapproved good, which means it's not been assessed for safety, quality or efficacy for inclusion in the ARTG. And what that means is that our ability to apply controls to it, because it's not a registered good on the ARTG, are somewhat limited. What I will do is I see my colleague, Mr McCabe, at the table, who we're working with very closely in terms of prescription monitoring and national harmonised policy.
Senator Daniel McCabe, Medicare benefits and digital health. Just picking up on your point about the challenges with medicinal cannabis and terminology, we have a significant piece of work underway with the Australian Digital Health Agency to go through and methodically codify all the different variations of medicinal cannabis. That work is ongoing and working with medicinal cannabis stakeholders to build out a comprehensive list of terminology under what's known as the Australian Medicines Terminology Framework.
So what would be the end product of that for a prescriber, for example? Would it mean that they would be consistent language, consistent methodologies across all the different state platforms? Would that be one of the outcomes?
Part of our challenge, which is why we've been working through this, is that we haven't been able to codify medicinal cannabis to support state and territory scheduling regulation because we haven't been able to identify all of the different variations. So getting nationally consistent terminology will then support state and territories with their real-time prescription monitoring systems to best capture information about it.
And are you seeing that as a kind of essential precursor for the work that you're doing, Mr. Lawler?
I think it's safe to say they're complementary, Senator. One of the challenges that we have is that the predominant mechanism we use to control drug names and consistent terminology is through stipulation of how medicines are entered into the Register of Therapeutic Goods. Medicinal cannabis products are not. And that's why we are working towards exploring reform of our regulatory processes towards medicinal cannabis to provide more effective standards and controls on that basis.
Yeah. So, for the purpose of registering for the TGA, what's the institutional block for that?
The institutional block is that, as with other medicines, we undertake an evaluation of safety and quality, and depending on the nature of the medicine, efficacy. And there is a need on the part of a sponsor to demonstrate against those criteria. And the challenge that we have is we only have 2 cannabis-based medicines on the register, and they have very specific indications. And
this is what's sometimes described as the evidence gap for the efficacy of some of the medicinal cannabis products to meet the standards or to meet TGA regulations, at least. I'm not suggesting they're not efficacious.
And nor are we in the first instance, but it's not just effectiveness, it's also safety as well.
Right. So the call that I've been hearing is for a national uniform real-time monitoring program credentialing process that removes that administrative duplication, and that requires, in part, your work, Mr. McCabe, in the digital health space.
Yes.
But if that was completed,
that would be an input into the work that we're doing.
There would be an input in the work, but then would it require the sponsorship and those further elements, or is that not essential for?
I might just jump in if you don't mind. Senator Professor Robin Langham, I'm the Chief Medical Advisor of the TGA. I chair one of our important external working groups, which is the Medicinal Cannabis Expert Working Group. What you're talking about is how we track and trace, if you like, medicinal cannabis products. And we've, through our work on the Expert Working Group, have done quite a bit of work with the organisation that attaches a specific number to each product so that it can be tracked through the real-time prescription monitoring program, and that's CSIRO. And CSIRO run the system which attaches a specific, it's called an AMT number, an Australian medicine, something around
terminology.
The number. But the difficulty that they're having is underpinned by the sorts of things that Mr. McCabe is talking about, which is having a transparent and an understandable and a reliable terminology process, so that CSIRO are able to get to something and give it a number. They have attached numbers to 200 of these unapproved products, but there are 1,400 of them in circulation. So
credentialing, numbers, arm twisting, is that kind of where it's going to go?
As Professor Lawler has already said, it would be terrific if drug manufacturers would bring us these products for evaluation so that they could be listed on the ARTG. But whilst they're unapproved, it's absolutely about how we track them, their Schedule 8 medicines through the real-time prescription monitoring, and that requires a number.
And then,
I think also, Senator, if I may, the way you characterise it through to arm twisting, I'd preferably describe as the compliance pyramid. But one of you mentioned the evidence gap and the impediments to registration. I would also say that one of the challenges that we face is that while medicinal cannabis is accessible through an unapproved goods pathway and frequently through telehealth or face-to-face consultations that are not MBS subsidised, so they're not easily quantified, and similarly scripts that are not PBS, so they're not easily quantified either. The incentive to have a registered product is actually lower than it would be for others. So that's one of the reasons why we see a large volume in unapproved goods approvals, and why we're looking at whether this access pathway is actually fit for purpose.
For the actual, those producing the product, they're not seeing the economic incentive to go through that process.
That's correct.
That's correct, Senator. But through our consultation that Professor Lawler mentioned before, we have had industry submissions where they do see the benefit of having regulatory oversight, and particularly in areas around quality of the product and supporting the quality of the product.
So I think we could explore this more, and just in the time I might move on to another aspect about also medicinal cannabis. It's about the vaporizers and the thread batteries. They're essential administration devices for, I have TG093 compliant medicinal cannabis, but those devices are still classified under consumer vaping regulations, and that makes access difficult, sometimes impossible, legal access at least, difficult or sometimes impossible for patients who need them for legal medicinal cannabis use. Has this issue been raised?
Well, we actually have Mr Jamieson here who can talk to you about how the vaping devices are registered with the TGA and the ARTG. So they are approved products.
Does that include the 510 thread batteries and a suite of vaporizers? How does it work?
Thank you, Senator. John Jamieson, Medical Devices and Product Quality Division. So the kinds of products you're talking about are medical devices. And so for approval, it's the same sort of, loosely speaking, it's quite similar to the medicines approval pathway. So for registration on the Australian Register of Therapeutic Goods requires a sponsor with safety and performance and quality evidence. There are 2 sponsors of products on the register that are approved through that pathway with 4 products. We've published a list on our website of those products that have that approved pathway. But there are a lot of products that are supplied outside that.
Mr. Jamieson, where would people find that list on the website? Because one of the calls that I'm hearing is to establish a regulated list of certified medical grade cannabis administration devices. You say there is a list somewhere?
There is a list.
It's only 2 devices.
There are 4 devices from 2 sponsors. Yes.
Right. I mean, one of the issues here is the devices, in the broader market are incredibly low cost, and therefore the cost of sponsorship is a significant issue. Is there an exemption pathway for medically required vaporisation devices? And it's been suggested to me that that's been used previously for things like glucometers. Is there an exemption pathway?
Senator, yes, there is a pathway for a special access. It's the same pathway for any kind of unapproved medical device. For instance, a glucometer that's not approved, or a CPAP machine that's not approved.
Yep.
It's through.
Have you been reading my notes? Because the other one was here with CPAP machines. That's got good eyes.
But that requires a doctor to arrange seek approval to supply it for their patient.
So that's a patient by patient process, is it? All right. So that is open, but it's only on a patient by patient. And if you want to sort of system-wide thing, then the sponsorship process is what's got to go through. Is that...
That's right, yes. The other, I mean, we mentioned, or I mentioned before, that there was 2 entries on the register of approved products with 4 devices, and we've published that on our website. The other point I will make, Senator, is that we are working with other medicinal cannabis vaping device sponsors towards who have the view for registration.
Okay, so that list may well expand.
Yes.
I've got a bunch of other questions, some of which I could probably put on notice. But one issue again, particularly when I go to Australian growers and Australian manufacturers who are sometimes incredibly frustrated that they're held to far higher standards than importers. One of the things they're calling for is a national framework for labelling consistency, THC percentages, terpene profiles, batch testing. Is there work on track for that national framework for consistent labelling?
Senator, all those issues came very clearly through the consultation process.
Yeah.
So in the very near future, we'll be publishing the submissions and the outcomes from that consultation process, and then we're looking to undertake some more targeted consultations with industry, relevant consumer groups and clinical groups to come up with some options to present to government, particularly around labelling, the regulatory pathways and THC concentration.
So would it be fair to say you've heard that there is a sort of broad push towards this, probably what the devil's in the detail about what it actually looks like?
Yeah, and making sure that we bring all those views together and start to bring together some options.
All right. Thanks very much, Chair. And
Thank
thanks
you,
everyone.
Senator Shoebridge. Senator Roberts.
Thank you, Chair. My questions are for Interim CDC. Sorry? Dorinda, we're waiting for them.
They're coming, yeah.
Yeah, Paul should be here. Should be Paul's here.
We could do these.
We just take a short suspension. We can.
I've got questions for you, don't even wait.
If it's just a short block of questions, and then we'll go to Senator Roberts.
Okay, so just following on earlier from Senator Hodgkin-May's questions. Earlier, Professor Lawler, you said that, and I hope I'm not misquoting you, something along the lines of, in the post-market space, when we receive signals, sometimes when we assess the information around the device, we look at the classification and assess if it's still fit for purpose. When you say signals, does that mean reports of adverse impacts?
Thank you, Senator, for that question. I don't remember specifically saying that, but certainly from the point of view of what signals are, yes, we receive signals in the post-market space, and that can be across all of our therapeutic goods, medicines, devices and the like. And what it relates to is if we are identifying through analysis of adverse events, sometimes when we have specific and direct approaches from stakeholders, including patients, healthcare providers, jurisdictions, or if we are seeing similar signals or similar instances occurring in other jurisdictions, such as other regulators. We will analyse that. We will determine on a risk basis whether any regulatory action is required, and we'll take that regulatory action.
Okay. So do I take it from that you would wait for reports of adverse incidents before assessing if a classification was fit for purpose, or...?
We undertake, if I may, Senator, the role of the regulator is to balance access to innovative, new and emerging treatments with the risk that they may potentially provide. So we undertake pre-market assessment. We don't simply approve and wait for things to happen. We undertake a fairly robust pre-market assessment on medicines and devices.
So once it's in the market?
Once it's in the market, we undertake post-market reviews that may or may not be triggered by signals.
Okay, may or may not.
Yeah, locally as well. I mean, and again, I want to be really clear that we are constantly kind of scanning the environment globally, so that if we are seeing signals that are being picked up by other regulators, we respond to those locally as well.
Okay. So just particularly in relation to the questions that were asked around Asherman syndrome, so I understand from your responses that sharp curettes are classified as class 1 low-risk devices, which means there's no reporting or mandatory reporting of adverse incidents. Is that correct, from what I heard?
If I may, Senator, thank you for the question. Dr. Marcel Noja from the Medical Device and Product Quality Division. This is a fantastic question and goes to some of the changes that we've been making in the mandatory reporting space. So later this year, in March, it will become mandatory through a tranched process for medical device adverse events to be reported to us from healthcare facilities. So we will start off with the most severe adverse events as well as deaths. They will commence in March this year, and we'll progressively start to add additional reporting through to us. With Class 1 devices at this stage, they will not become mandatory. However, we are working with the Commission on Safety and Quality in Healthcare to look at reporting more broadly, because as we know from the Senate inquiry into MESH, there were a number of adverse events through which the TGA was not aware of the signals. We are also working closely, and most recently we contacted a number of gynecologists and obstetricians and gave them updated information about Asherman's and asked them to report to us any incidents that they may receive. So we take a really broad approach to trying to get the signal information to the TGA, because we know that patients report to us, we know that sponsors have to report to us, and we will get this additional signal also start to flow through from the healthcare facilities.
Okay, so last year I think the government confirmed, I don't know whether it was here in estimates, that there's no routine data collection on the adverse outcomes from D&C procedures. Is that correct?
There is no collection that comes to the TGA. I can't confirm if there is another data set that comes to the government.
Okay, maybe I could speak to the department. Is there a data set that comes to the government, or would it be you'd expect it to go to the TGA if there was one?
We might need to call Duncan to come to the table.
I think probably just to be clear, if I may, Senator, that we would expect, and as Dr. Noja has highlighted, as the mandatory requirements are progressively implemented, we would expect those reports as they relate to devices and adverse events. But in terms of the clinical outcomes, including negative clinical outcomes from DNCs, that's not something that will come to the TGA, because that's around clinical practice rather than therapeutic goods.
So I'm just sort of trying to get it. So is it the case that this issue is sort of stuck in a cycle of there's no reporting of adverse incidents, so the TGA is not receiving enough signals that would actually require you to seek to reassess your classification?
Well, and again, I'll ask Dr. Noja to comment, but I think it's important that we don't, I think, allow the impression to be generated that if we identify a signal in a particular class of device, then we don't respond to that. we respond to it when we identify it.
If I might add to that, I think I might just briefly describe some of the broader approaches to post-market, because the signal detection piece through those adverse events is one component. There is a few other components that we also undertake. So we have a team within the TGA in the post-market space who have responsibility for clinical evidence. And what they do is, if we start to see a signal, and as we have with this, we undertake a clinical review instead.
So just step me back. What would trigger that? Because it's a Class 1 classification, which doesn't require this to be reported. So how on earth would you even know?
So we do regular scanning of health conditions that may be associated with devices. With this one, because it was discussed through a number of forums, we did raise it with our international counterparts to see if they'd had reporting. We did obviously discuss it, as mentioned earlier, with the Women's Health Product Working Group. And because of those discussions and what we were hearing from patients predominantly, we did go ahead and trigger that clinical review to see what the evidence and what the research was showing in relation to Asherman's.
Yeah. I mean, it sort of strikes me is that unless you actually have a change of classification, potentially it's going to be difficult. So just
I would also highlight, just a couple of things, if I may, Senator, to add to Dr. Noja's response. There are a few issues. Sometimes when we don't simply classify a device into a particular class and then register. We may impose conditions of inclusion. So if we are aware of any concerns that are relevant to a particular device, then we may actually put in additional conditions on that. I also would highlight that while we are working to implement a process of mandatory notification from healthcare facilities, it is a condition of listing that sponsors report adverse events as and when they become available. And I also would highlight that it is not simply the fact that we await adverse events in other countries as well. We also look to the changes in the scientific literature and the understanding around how devices are accepted and used in clinical practice.
Okay. So I suppose, part of this is around people understanding, getting the information. So, I mean, and it may not be your issue, Professor Lawler, it may be the department, I don't know, but what is being done to improve the awareness of the potential complications amongst patients and clinicians around the potential impact of D&C procedures and including the awareness of Asherman's syndrome?
I think this is an important reflection of the key role of the TGA in working with clinical stakeholders. We, as has been mentioned previously today, we convene the women. We have representation on the Women's Health Product Working Group, which has key clinical leadership organisations within it, including the College of Obstetricians and Gynaecologists, and also the ANMF, the College of Rural and Remote Medicine, and also the Consumers Health Forum. So we endeavour to ensure that there is an understanding within both clinical and consumer bodies to that extent. As has also been mentioned, we've been doing some work with the Commission of Safety and Quality in Healthcare on clinical guidelines and standards and the understanding of that. It's important to note as well that part of our role is to encourage and improve the facility for patients and health practitioners to report when they have had negative experiences or adverse events related to medical devices. So that goes to our ability to raise the understanding of what concerns may be there.
Yeah, sure. So this probably is one back at the department. So obviously there is a risk of Asherman's as a result of these particular treatments. So I'm interested to understand, has there been any action taken through whatever mechanisms are available to the government around, diagnosis of treatment of Asherman's syndrome, becoming more accessible, or making diagnosis more enabled and treatment of Asherman's more accessible as a result of the information that has obviously been generated through the work of Professor Lawler and his team?
I might ask the CMO to comment, and I don't know if Ms. Dr. Devlin wants to know. Yeah.
I'm sort of interested in understanding how this sort of plays into improvement of screening of Asherman's for women with fertility issues and how that actually plays in to the role of IVF.
Senator, perhaps while we're getting ready, I might just add that in late last year we did write to all the colleges and alert them to the importance of looking at Ashman's syndrome and the potential impacts of sharp curettes and other intrauterine treatments. We provided that information and let them know that we were looking at it and reminded them of the RANZCOG guidance in relation to this. I will hand over now to...
I've actually been communicating with the President of RANZCOG since the discussion earlier in the day. I think we'll need to go to RANZCOG and just get some more definitive advice for you.
Sure, I'm more than happy to wait because it's obviously a very important issue, but if it was able to be provided, because it strikes me as that there's a bit of a disconnect around all these particular issues, and then you sort of end up with a woman seeking to become a mother and being challenged by all of the implications of what's happened before. So that would be fantastic if you can come back with that. Thank you, Chair.
Thank you very much, Senator Ruston. Senator Roberts, we'll return to you.
Thank you, Chair. And I'd like to ask questions of interim CDC briefly, then National Health and Medical Research Council, then briefly, and then the Australian Institute of Health and Welfare. So if they could come to the room if they're not here.
We did give them a heads up.
Did you? Okay, thank you for being here tonight. Have a good evening. Can I refer to an answer by Ms Wood in December estimates, December 2025, regarding potential research function of the CDC? Your answer was very carefully worded, quote, "The CDC won't be conducting research on matters that are in the remit of other organisations. The CDC is a complement to the Commonwealth public health capability. It will not be taking over or otherwise leaning on research conducted by any other Commonwealth entities." End of quote. That's not a no. Can I have a clear answer, please? Will the CDC be conducting or causing research to be conducted? Yes or no?
Thank you, Senator. Paul McCormack, Acting Director General, Australian Centre for Disease Control. One of the functions for the CDC in our legislation is to advise on research requirements, specifically as it relates to public health matters. So we will be undertaking that, and so therefore an active participant in research. We are not researchers ourselves in the sense of producing primary evidence, though we are an expert organisation, and a number of our staff we would expect through the course of their work would be participating in research undertaken cooperatively with institutions such as universities, etc. But we're also not a funder of research. The principal funding mechanism for medical research in Australia is, of course, the national, the NHMRC, complemented by programs administered by the department, including the Medical Research Future Fund. So it's not a question that necessarily provides for a very simple yes or no answer. It's a bit of yes and a bit of no. We're a participant. We're not a principal researcher. We're a supporter of research strategy. We're not a significant funder of research.
So you'll be participating in research, but you're not researching?
Well, it's not a simple yes or no thing.
That's right.
We don't.
Yeah. No,
we have a role in research under our legislation, but it's not to be a prime driver of research.
Yep. Thank you. You haven't got hold of the beakers and the test tubes?
We do not have hold of the beakers and the test tubes, no.
Right. Thank you. A further part of that answer was that the Gene Technology Standing Committee oversees gain-of-function research through the Office of Gene Technology Regulator. The Standing Committee has not met since 2023, and their website last updated in 2024. The website of the Office of Gene Technology Regulator does not mention gain-of-function research. The only times they have interceded on the topic was for medical research where they defended and approved the application. So I'm pursuing this line of questioning because gain-of-function research gave the world the MERS virus and the COVID virus. President Obama banned gain-of-function research funding in 2014 owing to lab mishaps with anthrax, smallpox and avian flu. Every time I ask this government about this topic, I get an evasive answer. The Office of the Gene Technology Regulator has just approved a public trial of gain-of-function research which produced an influenza virus replica, so Australia is doing gain-of-function research and the regulator is approving it. Minister, will this government ban gain-of-function research?
Senator, I don't have anything to add from answers that I assume have been given to you over many estimates and the information given by the officials tonight.
So you won't, thank you. Well, One Nation will ban gain-of-function research.
It's great to hear about your policies, Senator, because then we know exactly what the Liberal National policies will be in a few months' time.
Well, we have been setting the agenda.
Thank you.
Could I turn to the National Health and Medical Research Council, please? Thank you for appearing. Good evening.
Hi.
In 2025, National Health and Medical Research Council funded the Vaccine Adjuvant Discovery and Development Centre of Research Excellence, CRE, with $5 million, part of a $72 million CRE package, led by Professor Catherine Andrews at Griffith University. This grant focuses on discovering new adjuvants to enhance vaccine efficacy and safety and related purposes. First question. Why do we need new adjuvants? What's wrong with the existing adjuvants?
Hi, Steve Westling from the NHMRC. I'm the Chief Executive Officer. We assess grants through a peer review process, and that process we utilise experts from around Australia to assess all of the grants that come to us, whether it's for a Centre of Research Excellence or an investigator grant or an ideas grant. The way that CRE would have been assessed would have been through that peer review process. Through that peer review process, they would have been elevated to the top of that scheme and would have been funded on the basis of their peers, indicating that this was high quality research that was likely to have a significant impact on health in Australia. We would take that on board, and therefore, if they were ranked accordingly, we would fund them.
So you don't know the reasons why the peers elevated it to number one?
Well, I would have to go back and look at all of the assessments by those peers, and obviously I don't have that directly in front of me at the moment.
Could you do that on notice, please?
We could, absolutely.
We'd like to know why that research was approved for new, and why do we need new adjuvants, and what's wrong with the existing adjuvants?
Very happy to look back at the peer review, but what I can guarantee you is that they would have been regarded as excellent research, likely to produce significant impact.
I'd like to know what they are.
Sure.
Thank you. Adjuvants and vaccines are there to enhance the body's immune response to the antigen. Common adjuvants include aluminium hydroxide, aluminium phosphate, amorphous aluminium hydroxyphosphate, sulfate, and potassium aluminium sulfate. These have been widely linked to neurological conditions spontaneously occurring after vaccination. Is this program an admission that there might be a level of truth to the link between aluminium and vaccines and autism? I guess you wouldn't know because you don't know that.
So you're asking us, the fact that we funded the CRE, is that an admission? So we would have again funded the CRE on the basis of the scores that the CRE obtained. Those scores would indicate the quality of the science and the likelihood of obtaining high-quality evidence to improve health of Australians.
Right, and you're going to find the reason anyway. So perhaps you could check if there is any aspect of truth to the link between aluminium and vaccines and autism as part of the reasons for developing a new adjuvant.
We can certainly look at the arguments that the CRE made and the peer review of that CRE. Yes.
Thank you. If research is successful and you find an effective adjuvant that is not neurotoxic, who will own the intellectual property? The taxpayers just funded.
So the way our granting system works is that the intellectual property developed by the people who get the grants from us, which are normally medical research institutes or universities or members of those organisations, own the intellectual property. And so the intellectual property would be assigned according to a university's intellectual property rules or a medical research institute's rules. And I'm not sure with that CRE where they were.
Okay, thank you. A $5 million Synergy grant was awarded in 2024 to a multi-institutional team, including Monash University, to optimise vaccines for respiratory viruses like influenza and RSV. This includes evaluating safety profiles to improve protection while minimising risks. If that develops new technology which achieves that objective, who will own that IP?
Again, the IP would be organised according to the rules developed by the organisations as a part of that Synergy grant. Synergy grants tend to have a number of organisations from around Australia, so I imagine there are multiple universities and MRIs involved in that Synergy grant, and they will have developed a IP policy, and the IP will be owned according to that policy.
But not by the Australian
Not by
government.
any HMRC or by the government, no.
We're very concerned about the level of spending in this government. Professor Bet Lui, National Centre for Immunisation Research and Surveillance, received a $2.79 million investigative grant in 2024 to study adult vaccination programs. This explicitly includes assessing vaccine safety, identifying risks in high-risk groups, and informing safer program designs. What was the outcome of that grant?
Again, if I knew the outcomes of all of the grants that I fund, we fund $1 billion worth of grants every year, I think I'd be pretty good. So I can't tell you the outcome of that grant, but we can take that on notice.
But you still think you're pretty good?
Do I think I'm personally pretty good or the NHMRC is very good?
Both. Okay,
Yes.
Thank you very much. I won't hold you against for not answering. Questions to the Australian Institute of Health and Welfare.
Good evening.
Good evening. It's hard to say AIHW. So, the Australian Institute of Health and Welfare Cancer Data in Australia in 2025 report emphasises that cancers, including breast cancer, are being diagnosed more frequently in people in their 30s and 40s, with the share of all breast cancer diagnoses rising about 50% over the last 20 years, which is stunning. Breast cancer is now the most commonly diagnosed cancer for women aged 20 to 39 and 40 to 59, which is surprising as well. Have you undertaken any analysis to cross-reference breast cancer in this younger cohort with lifestyle factors, drinking, prescription medications and so on?
Good evening, Zoran Bolovic, Chief Executive Officer of the Australian Institute of Health and Welfare. We do indeed produce the report that you're talking about and have a unit within the Institute that specialises in cancer data, its collection, national consistency around it, and then various types of analysis. And we often make the data available to researchers. Mm-hmm. For the specific question you're asking, I will defer to my colleague, Ms. Gates.
Yes, Louise Gates, Executive Director. Thank you for the question. Yes, as you said, we do produce that information about cancer. We do sometimes look at lifestyle factors. Specifically, it depends on what information we have around connection between having a lifestyle factor, such as risk factors around smoking or other risk factors. I haven't got anything to hand directly that we've done in relation to breast cancer.
Could you take it on notice to give us a range of what you do provide in terms of lifestyle factors, drinking, prescription medications and so on?
Of course, we can take that on notice.
We'd just like to see what you've got available.
Sure.
Thank you. The American Cancer Society call this, quote, early onset breast cancer. Specifically, have you cross-referenced breast cancer in this younger cohort with COVID vaccination status?
No, we haven't done that kind of work.
Why not?
I think we have provided updates, Senator, to this committee on previous occasions about the work we've done to create some data infrastructure that will enable various types of research to occur. That infrastructure is now largely in place. And we would expect that over time people will be undertaking various types of analyses using that data and other data that's available to them. But the Institute itself has not undertaken that specific type of research.
So you're more the constructor of the database and the ability to cross-reference, but it would be up to someone else who wants to do that to do it.
Senator, if I may, Ariane Herman, First Assistant Secretary, Chronic Conditions and Screening Division. Cancer Australia is undertaking a piece of work at the moment, directed by the Minister, to look at the impacts of early onset cancer, including looking at lifestyle factors and other factors that may be influencing earlier rates of cancer in Australia.
And what about COVID vaccination status?
I don't think that's included in what they're looking at.
It's not? I'm surprised, given what's in public domain about that. Have you cross-referenced COVID vaccination status with any health outcome in any demographic?
We have looked at vaccination status in terms of rates and that sort of thing, but no, we haven't looked at that in terms of any associations, no.
I'm surprised because of the news that's travelling around about that, including many scientists. This was the most significant health response in Australian history, that's the COVID injections, coming at a significant cost to the taxpayer, involving a significant level of coercion, which in hindsight was not justified by the risk. And the news about AstraZeneca and even the COVID shot, the Pfizer shots, came out very early, and the concerns. There's a widely held belief that the vaccines caused the adverse events, and nothing but denials from the government has come from. And this is not just this government, it's the previous government as well. If you have nothing to hide, Minister, why are you not doing the research which would confirm or disprove the link between COVID vaccination and adverse events and put a lot of people at ease?
Yeah, thanks, Senator, and thanks for the question. I think what the department and the officials have been able to explain to you is there is work being undertaken on a range of research projects that look into, trends in healthcare, whether that's post-COVID-19. There's a lot of time still to go before we see what that research might be, but the systems are being set up, and I'm sure that if there's any updates, they'll give them to you first and foremost.
Well, that's most unlike you, Minister, because it sounded like a lot of fluff, and that's not like you. So is your government afraid of confirming that the COVID shots cause early onset cancer? Or, because to me, people who have got cancer have got that thought in their mind. It's right through the community. And if people are worried and there's no connection, then that'd be wonderful to take that off their burden. So it sounds like bugger the people, just get on with the job and keep hiding it.
I think the most important thing to do is to listen to the experts.
And common sense and what people in the street are saying.
And the health experts, particularly the health experts.
This is a short paragraph from your website on suicide. Quote, although males are more likely to die by suicide, females are hospitalised for intentional self-harm with and without suicidal intent, almost twice as frequently as males. Furthermore, ambulance attendants data reporting on attendances for suicide attempts suggests females are more likely to attempt suicide than males. End of quote. This is a very difficult topic, but is it any wonder, really, that men kill themselves when this is how our health authorities minimise male suicides? Why are you conflating two different medical conditions, suicide and attention seeking, to minimise the fact that men are 3 times more likely to successfully commit suicide than women? Surely we have to get the truth out there.
Sorry, did you just refer to self-harm as attention-seeking?
That's quite often what it's labelled.
I just wanted to get that on the record, that a
Yes.
One Nation Centre is referring to self-harm as attention-seeking.
And quite often that's what psychiatrists will tell you.
I'm just always
What's the
shocked
answer
by
to
the
the
way
question?
that you speak about women and
What's the
their
answer to
care.
the question? Why are males committing suicide at 3 times the rate, and yet we're conflating the issue?
I mean, Senator, the AIHW can comment, but I don't think even the quote you've read out is conflating the issue. It's talking about different prevalence rate of if you like, attempted suicide or attempted self-harm and what the consequences of that are. That seemed to me a pretty straight factual statement that compared the impact on two genders of the patterns of reported outcomes and behaviour. So I would not accept the premise of your question.
Thank you. Thank you, Chair.
Thank you very much, Senator Roberts. Senator Antic.
Yeah, I've got some questions for the TGA.
Before you get started, Senator Antic, can I just, if you just indulge me, we are in the position now to release some more witnesses from this hearing. The Australian Centre for Disease Control, the Australian Institute of Health and Welfare, and the National Health and Medical Research Council. You are all free to go. Sorry, Senator Antic, you have the call.
Thank you.
They're coming to the table, Senator.
Yeah. I'll just wait for them all to. That's right.
We could probably start with Professor Lawler and then go from there.
Bring the right people to the table.
Yep.
Yep.
All right, well, I'll kick it off. Thank you, Professor Lawler. And there's a range of topics here, but I just want to start with this one. This has been sent to me. I can tender it. It's an advertisement for a website called knowandgo.com. 1 in 4 Aussies are at risk of severe COVID. Know if you're eligible for antiviral medicines. I can provide copies of those. And take the 2-minute quiz. And it appears to be promoted by Pfizer, a pharmaceutical company. The Act, the Therapeutic Goods Act and the Advertising Code are some of the strictest advertising laws in the world, including a clear prohibition on the advertising of prescription-only medicines to the general public. What does the TGA think of ads like that? Does that cause any concern for the Therapeutic Goods Association? They've been spotted on billboards and buses. There's a website. And really, the question posed by this is determining people's eligibility for COVID-19 antiviral medicines which Pfizer makes.
Thanks for that question, Senator. Certainly, as you highlight, we do have very clear regulations and expectations around the advertising of prescription medicines and therapeutic goods, as governed by the Therapeutic Goods Act and also the regulations. We do take each case on its merits because it can often be quite nuanced, whether it's the medicine itself being advertised, whether it's a health service being advertised, or indeed whether there is an encouragement to seek appropriate assessment rather than direct access to a medicine. But I have with me colleagues who are from our regulatory practice and support and also regulatory compliance branch.
Thank you, Senator. I might start and then Ms Lutton can add anything additional. I am Chris Bedford, the First Assistant Secretary of Regulatory Practice and Support Division. So as Professor Lawler has outlined, I'd like to have a look at the ad that you're referring to, because there are strict rules around the advertising of prescription medicines.
Yep. Sure. This website and this advertising campaign is not something that's currently on the TGA's radar for investigation, as far as you're aware.
Hi there. Tracy Lutton, Assistant Secretary, Regulatory Practice and Support Division. Just have received this advertisement, so I won't comment on this one specifically. But the TGA continues to actively monitor online content for potentially unlawful advertising of therapeutic goods and partners with several digital platforms to identify and address alleged breaches when they occur. For your awareness, in 24-25, over the financial year, we actually removed the over 13,700 unlawful advertisements, including whole profiles from digital platforms and sites. In 24-25, we continue to expand that piece of work, particularly working with digital platform providers, including major online retailers, to identify and remove that unlawful advertisements. Yep. We also work with several platforms in regards to, as I said, removing but also use our powers under Section 313 of the Telecommunications Act. And that is particularly where some of those websites are international, and I haven't had a look at this website particularly to comment, where Australia has no jurisdiction, and that will compel those ISPs or internet service providers to reroute that consumer or that purchaser back to the TGA website.
This is an Australian site.
I will also highlight, Senator, that's my understanding that this website, and I'm not in the position of defending a process that's undertaken by a private company.
There's anything wrong with it. I just want to know whether or not there's been a...
My understanding, and again, I'll be happy to correct if this is incorrect, is it assesses on the basic eligibility that are used by our guidelines for access to antivirals, and if you don't meet those, then you're found to be not eligible. If you do meet those, you are directed to a healthcare professional. You're directed to your GP.
Can I just ask you on the subject of advertising, because it's always struck me from the pharmaceutical industry that, of course, as we've said, advertising prescription medicine is illegal in Australia, but there is no equivalent for over-the-counter medicines, which of course are owned by many of the same companies. Now, the pharma market in Australia is something like $10 billion per annum. We don't know exactly I don't know exactly what the over-the-counter market represents, but it's something perhaps like 10 or 20% of that market. So pharmaceutical companies are, by definition, still pumping a lot of money into the media. Does that not give cause for concern when the media are reporting on health awareness campaigns, which may well drive sales in the pharmaceutical? There has to be a clear conflict of interest there, does there not?
So I appreciate that question, Senator, and certainly the regulations around advertising are very particular in Australia. Having seen the way in which medicines can be advertised fairly broadly overseas, I think that drives demand in a way that is not necessarily well informed and necessarily well informed by interaction with the health professional. I think it is important to note that, as with many of the other decisions that we make, the approach that is taken for the restrictions around advertising are risk-based. And one of the reasons that there are restrictions around prescription-based medicines is because these are medicines that have been determined by one of our delegates in approving and scheduling that these can only be provided in consultation with an authorised prescriber. So these are medicines that already have been pre-selected to be of higher risk. That carries with it potentially greater benefit, but certainly of higher risk, and that's why prescription medicines are prohibited to be advertised.
But the fact remains, though, doesn't it, that if media companies are obtaining a significant revenue stream from pharmaceutical companies, they're less likely to be critical of potential problems that arise with these therapies, with these therapeutics. Is there not any call, would you say, for a tightening of that, such that there is no revenue stream into the media which might have a natural reaction for the media to avoid criticising companies or their parent companies or the makers of other medication? I mean, they're the same companies.
I understand the point entirely, and I'm not really sufficiently expert to make comments on the decision process for media. I guess it does come down to a lot of the decisions that we make are decisions that be made by other parts of the medicine supply chain, which is that these are medicines of a lower risk type and individuals needing to be aware of the availability to gain the benefit. As I said, we work through the regulations that we have, and they apply most particularly to prescription medicines, but also to some other issues such as prohibited representations.
Okay, can I ask you about specifically about the flu vaccines? Pre-COVID in Australia, there were an estimated, I think, 300 to 1,000 yearly flu deaths from statistical models, and they're mixed in, I think, with some other respiratory illnesses like pneumonia. A recent preprint study from the Cleveland Clinic tracked about 53,000 employees during the 24-25 flu season, had an 82% vaccination rate, and found that vaccine hadn't been effective in preventing influenza. And in fact, it found that flu cases were actually higher among the vaccinated than the unvaccinated. Now, flu coverage in Australia among Australians over 65 and over rose from 25% in 2000 to 75% in 2019, and flu-related deaths have gone from 300 to 500 annually in the early 2000s to 953 deaths in 2019. If these influenza vaccines are effective, why have rising vaccination rates not been accompanied by a clear reduction in winter illness mortality, particularly among the older to whom they're targeted?
Would you like me to answer
Please,
that?
thank you. And first of all, is that correct? Are those statistics correct?
So could you just repeat the statistics?
Well, I mean, probably the most concerning one is that the flu vaccine coverage among Australians aged 65 and over rose from 25% in 2000 to 75% in 2019, but deaths from the early 2000s have risen from about 300 to 500 in the early 2000s to about 953 in 2019, which would suggest that the vaccination is not actually achieving the goals it was designed for.
Sorry, just one quick thing. I think it's really important perhaps that a more comprehensive answer just on the statistics themselves might be taken on notice. There are going to be a lot of factors that are occurring alongside. These are not trends, if verified, that have occurred in isolation. So over the time period you're discussing, we have had, for instance, I think if I have it correctly, the COVID pandemic, and so we're going to see some vaccination rates increase anyway.
That blocked out a few years, but the trend is just significantly higher for flu rate. I mean, this is the National Communications Disease Surveillance Dashboard, which shows a significant increase in flu cases. I mean, how does that overlay with a rollout of the vaccine program?
Associate Professor Catherine Gibney, ATAGI co-chair. So thanks for the question. I think it's really important that we need to understand the data and the statistics that you are referring to. One of the things about flu and surveillance data in Australia or anywhere is that it's really difficult to get accurate information about flu deaths using surveillance data. So I think we probably need to...
Sorry to interrupt. Why is that?
Because the notifiable diseases are notified at diagnosis, and we don't always get the outcome of the illness.
We could tell how many people died of COVID in 10.5 milliseconds, apparently, during COVID. We can't tell the same for the flu.
Well, during COVID, there was a lot of follow-up of all of notifications, and a lot of work went into understanding outcomes. I'm not saying that there is no good data on flu deaths, but we just have to really understand the data that you're quoting and whether it's consistent.
Not looking at my data, what does your data say about the increase in vaccination for the flu versus the rates of death and flu-related cases over a similar period, let's say the last 10 years?
So what I can say is that we have data on the effectiveness of flu vaccine in preventing hospitalisations is the most robust data we have, and that is published every year. And the flu vaccine isn't perfect by any stretch of imagination, but it does prevent a range, but around 50% or more of hospitalisations amongst vaccinated individuals, which is why we recommend flu vaccine and why it's funded for older Australians.
What are the risks associated with it?
With flu vaccination? Well, I think through the assessments of TGA and ATAGI, we can definitively say that the benefits outweigh the risks.
How?
Well, by preventing hospitalisations, by preventing many more hospitalisations than would be associated with the delivery of the vaccine.
Well, what if you've had a serious adverse reaction to one? What then?
Well, then obviously the advice would be that you talk to your healthcare provider about an individual assessment of the event, its association with the vaccine, and whether the risks and benefits of vaccine for that individual, where that lands.
I would highlight, if I may, Senator, that the analysis of effectiveness is predominantly on a population level. So it's quite reasonable, I think, for you to ask, what about an individual who has an adverse reaction? And the reason is because the benefit risk that we talk about is at a population level. That goes to the general immunity, it goes to the reduction in the amount of hospitalisation and reduction in deaths. The risk-benefit analysis for the person who has the adverse reaction is different, but you cannot know that prospectively, and it's very similar to the fact that the benefit-risk ratio for the individual who's infected with influenza or with COVID or with polio or measles is also different to the population risk-benefit of vaccination.
One of the concerns is that the difficulty people have in reporting. I think that's always been one of the criticisms of the reporting system is too difficult to report reactions, and so that will only happen in the case of severe reactions. Can I just turn? How much time have I got left, Chair? Chair, sorry, Chair.
Sorry, Chair.
Sorry.
I could make you the chair.
That was very unkind. I caught,
Sorry.
Sorry, I was just wondering how much time I have left for another.
Well, you can take as much time as you need.
No,
We're not cutting you off at this point.
Okay,
Do you need much longer?
I got another thing. I'm happy to flip it around, but I got some more after that. So can I do another?
5 minutes?
Yep.
Can I just reflect very quickly on one comment you said? One of the things that that I've discussed with yourself and also with other senators is that there's a large volume of adverse event reports for COVID vaccines, and we've seen that. The reason for that is because we have as much as possible made the reporting process easier. No, and the reason for that is because the validity of our post-marketing vigilance relies on us being able to access those results. So we have a very large volume of very useful data on vaccines, which gives us an understanding of the spread of the types of adverse events.
The criticism I hear is that the notification system is very difficult to navigate and very difficult, and not fruitful in the case of more smaller and minor adverse reactions. And by the way, I mean that post-marketing vigilance we have been asking for a significant period of time. I want to turn my attention though to a different type, the pertussis vaccine in children. There was, I think, a Productivity Commission report a few weeks ago which claimed that Australia is in the middle of an escalating whooping cough outbreak, and it's been reported all across the media that is the case. Once again, using the data from the National Disease Surveillance System, shows actually that whooping cough notifications peaked in 2024 at around 57,000 cases and fell to about 25,000 in 2025, indicating that the peak has already passed. Why, therefore, is the public messaging continuing to frame pertussis as a current and escalating outbreak when the data says otherwise? And does the department have anything to do to correct the ledger on that?
So just confirming that you're correct that the current outbreak peaked in 2024, but cases are still very elevated. The reasons include, so pertussis is cyclical, so we always have peaks every sort of 3 to 4 years pre-COVID. Then there was a bigger gap during COVID because there was less transmission of everything, essentially. And then we had a lot of people who didn't have natural immunity or had not been exposed to pertussis, had been vaccinated, but that just left a bit of an immunity gap, and so we had more pertussis post-COVID in this wave, but that is now reducing.
So would it be fair then for the department to notify our friends in the media that we are not currently at the highest watermark, or is there not an obligation on the department to do that? I mean, a lot of mothers would be particularly concerned about hearing that misinformation. We don't like misinformation.
If I may, Senator, Chief Medical Officer, we are still concerned about pertussis rates. We're always concerned about cases of whooping cough, particularly affecting infants under the age of 2 months who have not been able to be vaccinated. And those children, of course, are at risk if older siblings or older children who they may come in contact with acquire pertussis and infect them.
Some of these news organisations are reporting, and I won't quote the outlet, highest records of whooping cough since records began 30 years ago. Now, I know it's not your position to deal with what the media, but the media are saying this. Why doesn't the department, therefore, correct the ledger and make it perhaps a little less concerning for parents who might be worried about that specific fact, which not suggesting it isn't out in the community, but it is not accurate to say it's at its highest peak at this point in the last 30 years.
I would say that pertussis levels are still very high, so the public health messaging that childhood vaccination and maternal vaccination is important, that is still the case.
Are these just on the subject of that being important, and the risks in particular associated with this particular vaccine, we've been through this before, but I presume this also hasn't had a placebo-controlled test. I mean, there are different versions.
We have responded to those questions.
All right. On the subject then, just perhaps one or two more. Can the department provide year-by-year data on pertussis, whooping cough-related hospitalisations and severe outcomes from 22 to 25? Is there any explanation as to why these numbers are not readily available and prioritised for public communications, which would achieve the outcome that I suggested, which is that the ledger should be correct about the peaking levels?
Senator, we'd have to take that question on notice. I don't have those figures in front of me, but we can provide you that later.
Right. Does the pertussis vaccine prevent infection or transmission?
The pertussis vaccine protects against severe disease. It's not the best vaccine. It's the second time I've said that in answer to your questions, in short. But and you can see that by the fact that we give 5 vaccines during childhood and another dose in adolescence, and then on the NIP, and then recommend at least another 2 doses during adulthood, and that's aside from the maternal vaccines.
For pharma, isn't it?
Sorry?
It's a big payday for pharma getting 7 doses or whatever it is.
Yeah. Senator, if I may just add, it is a vaccine that does provide protection, but the antibodies that are produced by the body in response to the vaccination wane over time. Without those vaccines, the community would be at greater risk from pertussis.
But to be clear, this vaccine does not prevent infection or transmission, is the answer. I mean, I understand the arguments about severe disease and hospitalisation, but it is possible, is it not, for those who are inoculated to carry the disease, spread it, and not even know they have it, perhaps because of the dampening of the disease?
I would have to take that on notice.
I would say, Senator, if I may, just a couple of things. It is possible for that to occur, which is why we encourage, where possible, the highest level of vaccination.
So the vaccine doesn't work, so we've got to then give it to everyone.
The vaccine does work.
I think Senator,
Professor Lawler finishes answer.
I understand that it's attractive to represent the vaccine as not working, but that's not...
We need 7 of them.
Well, but you, as you've said yourself, the vaccine is as you've agreed, well, not agreed, but as you've acknowledged, the vaccine is very important for the prevention of severe infection or death. So it is vitally important that we recognise that, particularly in the instance of transmission, that we do try and maintain vaccination rates as high as they can. On your other question around whether it's a placebo-studied vaccine, we did respond to your question on that in SQ 25001578.
That's good on the WhatsApp. Excellent.
No, I have the record of when we responded to your question, Senator.
Okay. Yeah. Okay. Now, final question on this subject. If it doesn't stop infection or transmission or have an effect on herd immunity, the question that's of interest to me is, why are we forcing grandparents to be vaccinated before they can see their grandchildren, if it is, as we have acknowledged, not one of the best, or whatever the words were, vaccines? Why are we forcing grandparents to do that?
So I would say there's no forcing of grandparents to have vaccines. It is in the Australian Immunisation Handbook that people who live with or care for or have contact with infants who are too young to be vaccinated can consider being vaccinated. But really the main drive and the thing that makes the most difference is providing direct protection, which is through maternal vaccination, so that the young babies have antibodies in the first few months of life, and then the childhood vaccination, which begins at 6 weeks. And that is what protects babies from hospitalisation and death from pertussis.
Thank you, Senator Antic. Senator Ruston.
Thank you. I just had a few questions following on from Senator Little in relation to the National Mental Health and Suicide Prevention Agreement. Okay, just, I think I'm asking my own question, but can the Department confirm that the Commonwealth has offered the states and territories a 1-year extension on the National Mental Health and Suicide Prevention Agreement?
Senator, that's correct.
Okay. Have all of the states and territories accepted the offer?
Senator, it is my understanding that 5 so far have signed the agreement.
5 states? Okay, and which states are they?
The ones that have not are the ACT, Victoria and New South Wales.
I thought you said 5.
That's 5. So the 3 that have not of the ACT.
Oh, so they're the 3 that
that have
haven't.
not.
Oh,
yes.
sorry.
Just confirming it's probably easier to run through the 3.
There are a couple of quite big ones.
Yeah, a couple of big ones, yes.
Yeah,
but they're all working through their process. The message is they're working through their processes to confirm agreement to the extension.
Okay. So is it still the intent that the new 3-year agreement will commence on July 2026 or July 2027?
Senator, the extension is for the 26 to 27
26, so that would mean, so at the end of 27, this 1-year extension finishes. So is it the intention that there will be a 3-year agreement post that, or is that still up in the air?
That is a discussion, that is very much a live discussion of health and mental health ministers, who actually, we have a health and mental health ministers meeting on Friday. We have had sector consultation and discussions between governments that there would be intention for a future agreement, but that will be, of course, subject to government decision making.
The Productivity Commission findings of its recent report suggested or recommended the re-establishment of the Mental Health Commission and the National Suicide Prevention Office. Is that being considered as part of the new agreement, to your awareness?
Senator, that's best conceived really. That is really a matter for the Commonwealth Government as opposed to sort of an intergovernmental agreement with the states and territories, because the Commission is fully funded and established, had previously been established under Commonwealth legislation. So the Commonwealth Government is considering that. I think we have been pretty clear that it is an interim arrangement, that it is sitting within the department, and the government
So what is an interim arrangement?
With the move of the National Mental Health Commission currently sitting within the department as a temporary arrangement while the government considers its future sort of governance arrangements.
Minister?
Oh, I can't add to what the officials have said. I think it's under consideration at the moment.
So will you take that on notice? What?
Yeah, I can take it on notice, absolutely. And I can ask the Minister, and I mean, I think it's probably a bit late for me to try to get back to you tonight, but we'll certainly try to get that to you as quickly as possible.
Senator, what would also be, what would add to that, I think, is that the role of, while the decision on how the Commission is formed or where it sits would be for the Commonwealth, the role of the Commission in the national agreement in terms of sort of, reporting they do, as you know, the performance reports, etc. for it now. So the role of the Commission in a future national agreement would be something that we would negotiate with the states and territories.
And sorry, just to clarify, what I meant by it's under consideration is the way that it's established, but we are committed to establishing it.
Okay, fine. Yeah. So I don't know whether the Department knows this, or another one for you, Minister. Is the government intending to formally respond to the PC report and its recommendations?
Senator, we don't have a sense from government in terms of responding to the report. It was commissioned by governments about the previous agreement, and hence any response would effectively be what is the next future agreement, because the PC report was very much to inform that. So we anticipate that will really be the largest mechanism of response, is the design of any future agreement, as opposed to a response that might go line by line through the recommendations.
And probably just notify any formal response to the agreement, given that it's a Commonwealth state agreement, would require probably realistically a response from collectively of all the jurisdictions in one go. So it wouldn't be that the Commonwealth would necessarily respond on its own. So as Ms Devlin said, the response will really effectively be the negotiation of the new agreement.
Yeah. Just quickly before I hand back to others, in the National Suicide Prevention Strategy 2535, there was an ambition for the reduction of suicide rates, which obviously I think every single person would want to see. So I'm keen to understand there didn't seem to be, unless I've misread that, what was the specific numerical reduction in suicide deaths the government was aiming for in that 2035 under the National Suicide Prevention Strategy?
Senator, I don't believe that we have set targets or
There's no
forecasts
targets?
for future suicide rates in Australia. As you would appreciate, it's a devastating thing for families, but it is still a relatively small incidence each year. Whilst everyone is completely devastating, they are small incidences each year. It does move around because it is such small numbers. It does fluctuate. So the government has not set a target for the future.
Small numbers?
Small numbers in terms of the numbers of suicide.
Small numbers?
In relation to other causes of death, Senator, in that sense, but as I said, it is a devastating thing for any family to experience.
I think the other thing, just in terms of
3,307 Australians taking their death is a small number.
Senator,
with the greatest amount of respect, Dr. Devil, I'm not sure that I would consider that a small number of people who are taking their own life.
Senator, just to make sure everyone is perfectly clear on my comments, that is in relation to the other causes of death in Australia.
Okay.
Probably, Senator, just to add, I think one other aspect to that, the National Suicide Prevention Office is also at the moment developing an outcomes framework to sit alongside the suicide prevention strategy, which will, sort of, I think, be partly about how it looks to interpret the strategy from a what does it do, what does it mean, what does it achieve point of view.
Yeah. I've got to say, I'm not sure too many parents who've lost a child are particularly worried about an outcomes framework, but nonetheless. There was the funding package that was announced with the strategy included $69 million as a headline figure. How much of that has been spent to date?
Probably have to take on notice exactly how much has been spent, but it certainly has been, the majority of that is through the, a lot of that funding is through the National Suicide Prevention Leadership Program that is largely in contract. We could take that on notice to get you a figure of how much has been spent, but it would be under contract, with our providers in terms of doing it. So we can, if you like, give you an update on, there's a large number of actions underneath that funding.
Sure.
Which,
It'd be great to just know how much has been spent and how much is on foot to or committed to be spent. And so, in sort of, if you can get as part of that information for me, what are the measurable impacts that have been observed on things like, suicide attempts, emergency department presentations, and obviously the most important statistic of all of deaths, of how that $69 million or the measures that have made up how much of that $69 million have been spent in terms of the outcomes that have been achieved.
Senator, I would say that sort of obviously, from a suicide, from the statistics point of view, obviously there was 3,307 in 2024 and about 3,300 in the year before. So there's not a lot of variance between, the 2 years from that point of view, but lots of the programs don't necessarily take a reduction in the suicide rate as their overall measure of success. There'll be things from, a range of different things, whether they're sort of prevention, education and other things that...
But at the end of the day, we want to stop people from attempting suicide. We want to stop people from, who attempt suicide, who injure themselves, actually requiring medical treatment, and of course, most importantly, want to reduce and hopefully eliminate deaths. So they're sort of only in terms of the metrics of how you measure what your deliverables are. They're really about the bottom line in terms of what you're trying to deliver. So I'd just be keen to know how much of the $69 million has been spent and what the measurement in terms of the impact of that has been on those things that are actually the outcomes that we're trying to measure. It's not about outputs, it's not about actions, it's actually about outcomes.
I think I understand that, and I'm just probably flagging in the response for that from a attempts and from, we do obviously what we fund is the HW to do the data collection around around that provides the broader set of statistics, which of course we monitor and watch. But the attribution of the programs that we fund, which might be relatively, $500,000, $1 million or something like that, the attribution to that to a broader national data set on either hospitalisations or suicide is probably tricky to get that attribution from that program to that. So we'll take. I think I understand what you're trying to do. We'll get you as far as we can in that answer.
Look, and thank you, and I understand. But it would be really easy. It would be really nice to be able to get some of these answers in, like retail speak. What does it mean to Australia? You've spent $69 million. What's it done for Australia? So just finally, what are the top 3 cohorts where suicide rates are remaining the most stubborn or even potentially worsening, and what measures have been taken in relation to that? So just keen to understand, is there particular cohorts or target groups that you continue to focus on because of the...
Look, I think from a cohort, obviously males, statistically males die far more than are highly disproportionately flagged from that. So there's probably a range of different cohorts that we'd look at from that point of view. So that is definitely... Do you break
them down? Like, have you got a list of like...
Well, the data is available, so that is possible from that. I mean, and there is obviously... You can break it down by gender, you can break it down by age, and there are different priority groups within that. Sort of, I think it came up one of the other questions on notice, somewhere we had before around the types of occupations, and there is some work in looking at the that, which helps us from a targeting point of view. And of course, then there's a First Nations question, which is the one that is stubborn, is increasing, and unfortunately still increasing, that we talked about earlier.
Yeah.
They would be the target groups.
Okay, look, if you can just find a bit more data around this, just so we can understand, where you're targeting the money, how it's working, and because no point having a target to zero if we're not seeing any outcome.
Yep, absolutely.
Thank you very much. Thank you, Chair.
Thank you, Senator Ruston. Senator Antic.
Look, I think I probably don't have a huge amount of questions, but we'll just start with perhaps a question for Professor Kidd, actually. I've noticed this many times throughout the department's website, and I noticed it again on this. This is a statement from, I think, you on the 7th of August, a media statement talking about declaring syphilis a communicable disease, which is a reasonable thing to do. The line in here, though, that I'm interested in is congenital syphilis can be completely prevented through early detection and treatment of syphilis in pregnant people and their partners. And we see that term reflected a lot, this term pregnant people. Now, I've brought this in here. This is a pregnancy test. What would be the chances that if I took this right now that I might be pregnant?
I think we're allowed to have props in the Senate.
Just a question. I mean, without the prop, what would be the chances as a person? What would be the chances that if I were to take a pregnancy test now that I would be pregnant? And if not, what am I doing wrong? Because I've tried before and I can't seem to get one to say pregnant.
We don't really need to know what you do behind closed doors, Senator Antic.
That's a reasonable statement.
Just keep that to your
That's a reasonable statement. I mean, according to the professor here, pregnant people. So I'm people, and I just wonder what chance I would have of being pregnant right now, according to the department.
Do you want to identify as pregnant?
I could.
Do you want to take that, Professor Kidd?
You can take it on notice if you like.
Well, Senator, there are people in our community, as you well know, who do not necessarily identify as being male or female. Some of those people can become pregnant, therefore the use of the term pregnant people.
I see. So what about me? What chance would I have, do you think, of becoming pregnant if I was to be
I'm not going to make any assumptions about your...
Very good. It's bizarre, isn't it? It's unreal. Senator Roberts, would you like to help me?
No, you have the call. Senator Roberts does not want to interject on...
It's hard to know
and we
where to
don't
go.
do writing off the back of others in this committee. I'm sorry.
A 51-year-old male, who is a person, should be doing in order to achieve pregnancy? Something that I'm not doing that I should be, perhaps?
Are these questions for Professor Kidd?
War, isn't it? Always about the culture war.
Sorry, Senator
It's in the department's document.
Order.
Arguments that go nowhere.
Order.
Anyway, yeah.
Order. It is rather late, and I think Senator Antic, it'd be helpful for me as the chair to know who you're directing that question to, if it is a question.
Someone else in the department that can answer it. I mean, so far we haven't had much luck.
I think Professor Kidd did already.
Answered the question. All right, well, I'll just keep trying then. Thank you. I'll just keep going. I'll just keep battling away.
Great, thank you. That is...
Thank you.
Thank you, Senator Antic. Is that the end of your question?
It'll be a glowing moment in
Thank you. That concludes all of the questions. I do have a script and I will be that very quickly. Concludes all the questions this end. That concludes today's hearing. Thank you to all the witnesses who have appeared and to Hansard and Broadcasting for their assistance. I remind senators that the committee has agreed that any written questions on notice should be lodged with the Secretariat by Thursday the 19th of February 2026, and the answers to questions on notice are due by Thursday the 9th of April. The committee stands adjourned.